All right, y'all. Now we are in chapter 3, and this is your introduction to ICD-9. And you remember just from the outline and the basic makeup of your ICD-9 manual, and you know who is responsible for ICD-9 is the World Health Organization. So when asked who is responsible for it, you know it is the World Health Organization. We also know that the overview of the layout of ICD-9 is that we have volumes 1, 2, and 3. Now, as physician-based or pro-fee coders, we only use volumes 1 and volumes 2, with volume 1 being our tabular list, diagnosis organized in a code by order. Then volume 2 is the index of diseases, or the alphabetic index. The alphabetic terms organized in an alphabetical order and disease description for volume 1. And then, of course, y'all know volume 3 is for hospital procedure codes, which we do nothing with because we are outpatient coders. Now, you know October 1st of every year, we have to use our new ICD-9 codes and ICD-10 codes pending this year that we're going to go through, and we should. Now, knowledge. Whenever we code, you all remember that we code to the highest level of specificity, with the highest level of specificity being to the 5th digit if possible. Insurance companies like 5 digits, and they do not like 9s on the end of codes, because you know if you have a 9 at the end of a code, that means that is an unspecified code. And insurance companies like for us to be as specific as we possibly can. Now, volume 1 is our tabular list, and it has 17 chapters, and they are classified by disease, injury, grouped by the etiology or the cause of the condition, or the anatomic or body site. There are 2 additional chapters for supplementary classifications in the tabular list, and it's organized in 3 codes, and their titles are called category codes. And some 3-digit codes are very specific and are not subdivided. These 3-digit codes can be standalone, such as, you know, when we do a pneumonia for that 486, that's a code that can stand alone. We can't code it any higher, and it stands on its own. So there are some 3-digit category codes that can stand by themselves, and they are coded to the highest level of specificity. But for the most part, we want to be as specific as we possibly can when it comes to our coding. All right. We have also in ICD-9, we have in volume 1, we have V codes and E codes. And you remember I told you a V code is probably called my preventative medicine codes. That means that the patient does not actually have something, but we want to take preventative measures to keep them from developing something. So make sure you know what a V code is, and an E code is an external cause for injuries. So when you are coding 800 and 900 codes, you have to append an E code to it to make sure that the insurance company knows what happened to the patient. How did they get that injury? Because that is what an E code does. It tells how the injury occurred, where it occurred, were they at work or were they not at work. That is what an E code does. Now, volume 2 is your index to disease. You know, with any of our coding, we choose the main term first. Then we go and we look it up in the index, the alphabetic index. So when we find it in the alphabetic index, then you know we go and we verify it in the tabular list of diseases. Because one of the cardinal rule of coding, besides if it's not documented, it's not done, is we never code directly from the alphabetic index. Now also remember, you all, where your appendices are. You have Appendix A, and these are the morphology of the neoplasm, which we do nothing with. We have some deleted codes effective of October 1st of every year. The classification of drugs by the American Hospital Formulary Service list number and their ICD-9 CM equivalents. Then we have Appendix D, the classification of industrial accidents according to agencies. Then we have Appendix E. This is a 3-digit categories, the list containing 3-digit categories in ICD-9, and provides concise view of the contents of ICD-9. Next of all, you all will talk about conventions, and we know what conventions are, and there's no excuse for you not to know what these conventions are. They're found throughout your books. NEC, not elsewhere classifiable. Remember, layman's terms. The doctor got specific, but ICD-9 does not have a code for it. NOS, not otherwise specified, means what? This is an unspecified code. The doctor was not specific of what he really wanted, but there are a lot of codes in ICD-9 that would have given him a more accurate diagnosis. Brackets are used in the tabular list to enclose synonyms, alternative words, and explanatory phrases. Slanted brackets, remember, I told you, that should scream to you, don't code me first, I have to be coded secondary. In such a case where you have your diabetes with manifestations or your hypertension with the manifestation of CKD. Slanted bracket codes, we don't code them first. The parentheses, remember those are where our non-essential modifiers are held. Y'all, all of this is in front of your book, in front of your ICD-9 manual. They're there, y'all. You have your colon. This is a colon used in volume 1 after an incomplete term requiring one or more descriptions that follow may it be assignable to a given category. Remember, boldface, this is a title in the tabular list. Excludes, remember, excludes following notes are to be reported with a code from another category. So you cannot code those two things you're trying to code together. Use excludes in the tabular list guide, the coder, to a more appropriate code. Okay, so you can't use the two things you're trying to code together. Includes means it's included there. So make sure you know the difference. Use additional codes if applicable. You remember, if you have a use an additional codes term after a code, that means the one that you found is the first one that you should list, but the one that it tells you to use additional should be coded secondary. Combination codes. Combination codes are indicates a single code is used to classify two diagnoses, a diagnosis with associated secondary process or manifestation, or a diagnosis with an associated complication. Okay, we're going to have a lot of combination codes in ICD-10. Now, when you see the term code first, you have to do exactly that, y'all. If it tells you to code something first, you have to code whatever it tells you to code first. That will be the proper coding guidelines. Okay? Pay attention to your notes. As always, I tell you, notes are there for a purpose. They're trying to tell you something. They're trying to get your attention. You have to do what it tells you to do. See, it's this example right here with your myelofibrosis. It says code first the underlying disorder such as a malignant neoplasm of the breast. So you would code the malignant neoplasm of the breast first, then you would code that 284.2 secondary. Okay, that's how you do the code first. Eponyms. Now you all remember eponyms are named for someone who first had the disease, discovered the disease, discovered a cure or treatment. They are proper nouns and they are capitalized. Modifiers are 2-digit little characters that tell something extra about the code, but they don't change the meaning of the code. Notes are classified up under the codes. And is considered and or with means due to. C means that you have to go somewhere else and look something else up. C also means that you can find it the way you're looking up, but it's also available this way if you look it up this way. C category means you have to go to the category portion of the code where you started in order to find the code you're looking for. Of course, unspecified is our NOS. Okay. So we remember, we don't like to code signs and symptoms, you all, but sometimes it's necessary. If you do not give me a definitive diagnosis, I'm not going to code probable pneumonia. If my patient came in with cough and fever and the doctor says probable pneumonia, guess what? I'm going to code cough and fever as my principal diagnosis, okay? So we don't like to code signs and symptoms, but sometimes it's going to be necessary if a doctor does not give us a definitive diagnosis. You know where your guidelines are. Your guidelines are in the front of your book. And remember, I've told you all, in ICD-9, this is your Bible. You have to go by your Bible. So you need to make sure you know where your guidelines are if you're not sure about something. All right. Like if you, we never code anything that is integral to a disease process. So if you got a pneumonia, well, you know that all patients with pneumonia have cough and fever because one, the pneumonia is an infection that causes fever. Every patient's going to have a fever. Then you know every patient with pneumonia has a cough. So therefore, cough goes along with pneumonia, so we will not code a cough. Those two things are integral to the disease process, so they should never be coded with pneumonia. Combination codes, we have a combination code is used to fully identify an instance when two diagnoses or a diagnosis with associated secondary process, manifestation, or complication are included in the description of a single code. Assign a combination code only when the code fully identifies the diagnostic condition involved or when instructed to the alphabetic index. Okay. Acute and chronic, you know, we will always code acute before chronic because acute is a sudden onset and it needs to be taken care of immediately before it wreaks havoc. So we always code acute before chronic. Now, conditions that are not a part of the integral part of the disease process, if you have something that is not normally, like if you have a upper respiratory infection, then you have like a sign and symptom of knee pain. Those two things can be coded together. The knee has nothing to do with the lungs. So therefore, you could code those signs and symptoms with that upper respiratory infections. Multiple coding of a single condition. Make sure you go and look at that. Late effects, and we've talked about the term late effects before. We do late effects when you have had a disease or illness and for some reason the patient develops some kind of condition. Let's give you an example of a fracture of the arm. The patient didn't want to move, so they got a contracture now. That contracture is what is considered to be a late effects now. And in a late effects, the late effects is always coded first. And that late effects of that contracture, which would have been that old fracture, would have be coded secondary. Okay. So the actual ongoing problem is coded first. Then to let them know that it's a late effects would be coded second. All right. Late effects is that residual that remains after the initial injury, y'all. If you have a patient coming in